about microsurgery of third ventricle tumors, and I already published some papers and textbooks on the same subject during my life. As we know, the third ventricle is a cavity in the middle of the brain surrounded by very important anatomical structures, which are very important functional implications. So if we look at the boundaries of the third ventricle, anteriorly, we have the columns of fornix and the foramen of Moro, anterior commissure, lamina terminalis, optic recess, and chiasm. Lateral boundaries. Lateral boundaries is very important to see. We here have the Moro foramen. This is the very important thalamus striate vein, and laterally we have the thalamus. Inferiorly, of course, hypothalamus. The roof of the third ventricle. We see that we have the tela chorioidea and choroidal fissure, and we have two important veins in the roof, internal cerebral veins, and this is very important, and laterally always the thalamus. And finally, looking at the floor, we see the chiasm, infundibular recess, the tuber cinereum, and the mammillary bodies. So this is a small cavity and with very, very important anatomical structures around. I would like to remind a sentence of Roton about 20 years ago. It's impossible to reach the third ventricle without opening some neural structures. At present, we know that we can have an access to the third ventricle or with minimal neural opening, or, for example, in the case of translamina terminalis, without injuring any neural structure. So the situation was changing during the last decades. And speaking about the anterior lesions in the third ventricle, we had for sometimes the anterior transcortical approach, more often in the last decades, the anterior transcallosal, translamina terminalis, and I would like to remind the approach of transphenoidal endoscopic for lesions occupying also the suprasellar systems. This is my personal series of pure third ventricle tumors. I don't speak about tumors invading the third ventricle, but pure third ventricle tumors. And in these cases, in most cases, I used the anterior transcallosal approach, and I had a cross-total removal a little bit more than 70% in these cases. What are the problems in tumor removal, which are independent on its nature? They are deep-seated lesions, of course. Sometimes we need also minimal, although minimal, but neural incision. We have a narrow access through risky corridors, and sometimes, in some cases, we need a combined approach, but I don't speak about this in this presentation. So this is a central neurocytoma involving not only the third ventricle, but also the lateral ventricle. And the transcortical approach is a transsulcal transcortical approach, opening, as you see, the sulcus and reaching the lateral ventricle with sparing, so the neural injury to reach the ventricle. And you see this was the approach used in this case. This is the arrow indicating the corridor, very small corridor we used to reach the lateral ventricle and to remove this tumor. But in most cases, I use it and is used everywhere in the world, the transcallosal approach. Transcallosal approach, which is, of course, an approach through a very small opening in the corpus callosum. As you see, the problem with the transcallosal approach is the importance of sparing the bridging veins. As you see here, and the bridging veins, we can know, of course, before the operation, we can have the evaluation of the bridging veins with the preoperative venogram, as here. And you see that we can use a relatively small approach to go through the inter-hemispheric fissure just to reach the corpus callosum, as here. And the importance of moral foramen is obvious, because around the moral foramen there is the anterior column of fornix and the body of fornix. This is the injury. As we know, the injury to this structure can give some important cognitive disturbances and the memory disturbances. So the preservation of this structure is absolutely very, very, very important, as I said. So the moral foramen is used depending on its size, because this is very important. Otherwise, we need to have other typical approach that I will show you very soon. And the fornix preservation is absolutely essential. And the preservation of bridging veins, as I said before, the internal cerebral veins and the thalamus-striate veins. In some old, in an old paper, the paper was this was a form of Ish. It was said that thalamus-striate vein can be sacrificed and divided, but this is really dangerous. Probably in some cases it doesn't happen anything, but it's dangerous. The preservation of thalamus and the hypothalamic region, of course, and the importance to establish CSF pathways patency when you remove the tumor in this location. You can use different corridors, as I said before. Transforaminal is the mostly used corridor, but it depends on the size of the foramen. If there is a ventricular dilatation, so it can be feasible. In other cases, it may be difficult. Transfornical, I didn't use in my experience. Used in most cases a transchoroidal or subchoroidal approach, just to have a look from the roof directly to the cavity of the third ventricle. And finally, but only in some cases, an interfornicial approach, always from the roof of the ventricle. This is these are some few examples of these approaches. This is a colloid cyst and transcallosal interfornicial. This was possible also because there was a cyst of the septum pellucidum, as shown here. And you see that you can reach the corpus callosum and the pericallosal arteries, and you make an incision which is longitudinal, but some use a transversal incision. This is the opening of the cyst of the septum pellucidum, and this is the body of fornix, as you see, and the colloid cyst appearing through the foramen of Morrow. And this removal of these cysts was possible through the foramen of Morrow. But you have to know that this is also for colleagues using more often in colloid cysts the endoscopic approach, that sometimes you can have a bleeding, as in this case, and in this case you can control this bleeding very easily. But it's more important what I show you, that there is a branch of the posterior colloidal artery here, absolutely adherent to the colloid cyst. So this the removal is possible if you divide this branch, preserving, of course, the choroidal artery, and removing unblock the colloid cyst, which was a solid tumor. So you see from the roof the internal cerebral veins and the choroid plexus. At the end, you can have a look at the Sylvian aqueduct, as in this case. This is what I said before: the internal cerebral vein, the choroid plexus, the posterior commissura, and the pineal recess. This is pre-op and post-op of this case. And in more frequent cases are craniopharyngiomas, as we know, but I'm speaking about pure intraventricular craniopharyngioma and transcallosal transchoroidal approach, as in this case. It's a molar foramen. And I would like to show you that the craniopharyngoma was adherent to the border of the fornix. And you see the ependyma of the third ventricle. There was no adhesion, and in this case I used the subchoroidal approach. This is the thalamus-striate vein, and you see that we can control also the posterior portion of the tumor and remove it without injuring the ventricular wall. And you see that we can check both foramina of Morrow, as in this case. And here we have the thalamo-striate vein absolutely preserved, as you see here. And this is pre-op and post-op of this case. And just to see that which is the relationship in another craniopharyngioma with the border of the fornix. And in this case is more easy to dissect the craniopharyngoma from the border of the fornix and to remove pismal. I go fast. And you see at the end, we have the complete check of this Sylvian aqueduct, as we see here. So it's possible, the thalamus-striate vein, the entire ventricular cavity. So what are the advantages? For transcortical approach, probably the most important advantage is no risk of bridging veins impairment. But transcallosal approach has more advantages, as the approach to both foramina of Morrow, lesser. We have an incision of 1 centimeter, 1.5 centimeters of the corpus callosum. We have multiple corridors to that ventricle, and it's possible even in case of small ventricles. So as you see here, we have, I showed you before, we have absolutely control of the cavity from both sides. But this is I believe the last case, an approach, translaminar terminalis approach, which has the great advantage to that it does not involve any neural incision. We studied the lamina terminalis in the Department of Anatomy of Vienna with Manfred Schabischer and measured the sites of the lamina terminalis, which has no neural elements, just to have the idea how big we can have an opening of the lamina terminalis without injuring the optic nerves. So this is craniopharyngioma, always with a calcified solid component, the opening of the lamina terminalis, and we see immediately the calcified portions of the tumor, and we can remove pismal through this opening. And we need to preserve the pituitary stalk just to put in the underlying structures, and we can remove other portion of the tumor. You see, although this is a calcified portion, this is the basilar artery, and we have two windows, the lamina terminalis, two windows, and the optic carotid space, the optic carotid window. As we see here, this is basilar artery, and this is the possibility to work through different corridors, translaminar and optic carotid window. This is the post-op of this case. And going to the conclusion of this presentation, I would like to emphasize once again, also for the trainees attending this webinar, that anatomy guides the choice of approach, not because we are more familiar or not familiar with an approach, but the anatomy, because pure intraventricular needs a transcallosal approach, only sometimes a transcortical approach. A tumor located in the floor may be treated through translaminar terminalis and suprasellar systems. A tumor in the roof with the transcallosal and its variants, transforaminal, transchoroidal, interfornicidal, and I don't speak about combined approach for other locations. You see here, this is the intraoperative view, and this is the anatomical view. We need to know exactly the anatomy just to preserve very important structures we have in this area. In conclusion, the differentiation between pure and secondary intraventricular tumors has important surgical and clinical implications. For example, speaking about craniopharyngiomas, intraventricular craniopharyngiomas are characterized. This is the conclusion of recent, very recent papers by small sessile or pedicle types of attachment to the inner lining of the third ventricle that allow safe radical resection in most cases, as we saw in some cases I showed before. Gross total removal and clinical outcome depend mostly on biology and adherence of the tumor to the ventricular walls. There is a legend in neurosurgery that the transcallosal approach leads without any doubt to cognitive deterioration or to cognitive disturbances. This is a legend because if we can preserve fornix and the adjacent structures, as I showed before, the cognitive functions can be well achieved, preserved by microsurgical procedures. I thank you so much for your attention.
Francesco, thank you very much. That was a great lecture. And I believe you are perfectly correct that it's a myth that the psychological disturbance after transcallosal approach is a must. It's not true anymore. I would like to answer one of the questions which appears there and which I was asked to answer directly. It's related to my lecture, so Francesco, please allow me. Mr. Ducom asks if it is allowed to open the Lilienquist membrane upon dissecting a posterior clinoid tumor. All these tumors are approached by now from anterior. It means that in a way there is the third nerve, there are the major arteries, there are the perforators, and of course Lilienquist membrane as well. So you cannot remove posterior clinoid meningioma without cutting the Lilienquist membrane. It's a must. It's not unavoidable. It's really, you must cut the membrane. Well, are there any questions for Professor Tomasello?
Can I just make a comment? Because I loved your presentation, Francesco. I think it puts, especially the second to last slide with the strategy, that put really nicely together how we should think about approaching these lesions. It's an anatomical question. And for me, the guiding principles are the shortest possible distance to the tumor through cisterns or sulci, and minimal dissection of any white matter corridor on the way. So I personally would not recommend any transcallosal approach for someone who starts resecting tumors in the ventricles, because I think there's quite variability of where the fornix runs. And if the lesion is not perfectly midline, there's distortion, you may just hit the wrong side. So coming in from transcortical, transventricular right side, your chances of causing damage for vasculature, pericallosals or anterior cerebrals is significantly less. Your chance to hit the fornix is significantly less. Your bridging veins are not anywhere in the way. So you've eliminated three major issues and you get a very nice viewing angle for largely unilateral tumors. And I love the lamina terminalis approach, which is really subfrontal, with the exception of any retrochiasmatic lesion, which is difficult to see, just because in a craniopharyngioma that often has a calcified attachment behind the chiasm, that's the difficult spot to reach from sublamina terminalis. I think these two approaches are fantastic for someone who starts early on to venture into these ventricles and tumors therein. You gave a beautiful overview. I think that was fantastic. Thank you.
Thank you for your comment, Gerard. I think that we have different approaches and corridors we can use. As I showed you, I used also transcortical, transsulcal approach, which reduces the distance within the surface and the ventricular and the lateral ventricle. So this is. It depends on your, to some extent, on your familiarity, but also from the specific case. The location in the third ventricle, the size of a ventricles, so different variables that can guide in addressing your surgery.
Okay, we should go on, but there was one question from Gianni Brocci.
Yeah, I would like to make a comment. First of all, compliments to Franco. It's a wonderful presentation. I agree with Eckhart that for beginners or for not so experienced surgeon, it's better not to go into the midline and transcallosal. But we have to know now, today, that with DTI, we can know in advance the function of the fornices and all the structures. So I think that this will bring again, let's say, water to go through a transcallosal approach. I think that is very important. And I think that each surgery should be tailored for a particular case. So there is no one single approach, and that was the merit of the presentation of Franco.
I completely agree. This remark is very important, I think, and can be very useful in guiding our surgical plan. Thank you. Thank you, Gianni.
Okay, thank